So in terms of recent publications regarding the management of open abdomen that includes the device AbClo, I would like to comment on the East guidelines for 2022 that just came out, if I'm not mistaken, in September of last year. So the management of the open abdomen was the topic of the um, Eastern guidelines group, and they wanted to look at if strategies that could facilitate primary fascial closure. They were comparing negative pressure alone and negative pressure with additional strategies to try to bring the fascia together at the level of the midline. So they looked at 12 studies encompassing 378 patients on the arm of traction, in addition to whatever temporary abdominal coverage there was, and 304 patients with negative pressure therapy alone. And the four methods to medialize the fascia that were used was mesh-mediated reapproximation, the ABRA device, suture of the fascia and traction of that suture, progressively traction on that suture, and our device, AbClo. So here's an example of a progressive fascial closure, an example of the ABRA system, an example of the Whitman patch, and an example of the mesh-mediated fascial traction. And AbClo obviously was also included, as I mentioned. So out of all those 12 studies, only 4 studies were prospective and randomized. One with mesh-mediated, one with ABRA, one with suture traction, and our study with AbClo. When they looked at all the studies on this tree plot here, it was clearly shown that the addition of a traction system to any type of abdominal coverage favored, closure favored traction system over non-traction system. There was no difference in intra-atmospheric fistula, and there was a low degree of heterogeneity on these studies. If you eliminate the studies that were not prospective and you look only at the prospective studies, similar results show. So fascial traction was favored for primary closure of the fascia over non-traction, and abdominal closure was actually sooner, 4 days sooner, with if you apply any type of traction system. So the grading of evidence for these recommendations were not strong because there were many retrospective studies and poor quality studies. But the committee concluded, or the authors concluded, that they conditionally recommend their use because it improves the rate of primary myofascial closure in open abdomens. So again, I'm going to touch on the paradigm shift, and this is the last section that I'm going to talk about here. So the problems that we face today with the current technologies of fascial approximation in open abdomen is that the technologies or the methods today are invasive. They damage the fascia and they damage the skin. This goes against all the principles of fascial preservation in abdominal wall surgery. Another problem that we have is that they require placement, or at least most of them, in the OR and adjustment in the OR. So to readjust these devices, most of them, you actually have to take the patient to the operating room. And because of that, surgeons usually delay the placement of those devices or methods, and that causes gives room for the rapid increase in the size of the defect because of fascial retraction. Several factors could interfere with a timely uh, closure of the open abdomen. Sometimes we have patients that we plan on closing them in 24 hours, but because of logistics problems, for example, the OR is too busy, more patients come in, they have priority over more stable patients with open abdomen, and then we push these patients back another 24, another 48 hours before we close. And during that period, the retraction of the fascia is happening rapidly. So because current methods damage the fascia, surgeons avoid avoid using them from the get-go as a preventive approach. So these methods here deter surgeons from applying them early because of this potential for complication. AbClo is non-invasive. We don't require taking the patient to the operating room to put this on. We put it at the bedside with a nurse. No sutures are required. No anesthesia is required. As I mentioned, bedside placement. And at the end, you can barely tell that the device was placed on the patient. The key point here is the device needs to be placed while the muscles are still mobile in the beginning, in the first 24 hours of an open abdomen. The device engages the transverse and the obliques, including the rectus, delivers gradual traction towards the midline, preventing lateralization and loss of domain. One question that I often get about AbClo is, oh, you just created a fancy abdominal binder. Oh, we can replace that with a pelvic binder of any sort. No, this is a different device. It has nothing to do with these devices here that work very well for the purposes that they are designed for. Actually, the rigid plate that AbClo has, and it's a curved rigid plate, it actually engages the lateral edge of the rectus abdominis muscle and pushes it towards the midline. The device also has a gauge connected to an air-filled balloon that allows the user to know the tension that's being applied onto the tensioners or onto the abdominal wall. And this is an important asset of this device because it allows for nurses to control the pressure and as a safety measure to prevent excessive traction on the abdominal wall. So the device pushes towards the muscle, towards the midline. And as I mentioned before, the entire abdominal wall is moving, not only the skin. This is not shearing the skin over the muscle. Even in patients with large BMI, we've used this device in BMI of 61, and again, we can see that the edge of the skin and the edge of the fascia or muscle are one right below the other on these CT scan cuts. If the institution does not use a negative pressure therapy, the AbClo can still provide the same type of benefit. Here are some examples. This is a patient that had an open abdomen, started off with 15 centimeters. Then a few hours later, we had 7 centimeters, 4 days of open abdomen, 2 take-backs, each take-back to require the Navthera, 9.2 liters positive, and we had primary closure after 4 days. Another case here, 7 days of open abdomens, 3 AbTheras, 3 take-backs. The patient actually had a stoma. We can make an opening on the binder, on the elastic band that goes behind the patient's back and to accommodate the stoma, and again, primary closure. If you look at the skin here, you can barely tell that there was anything over there, just a minor bruise there. In terms of cost analysis here, we all know that open abdomens lead to 3 times complication rate, increases length of hospital stay significantly, number of surgical procedures, and in terms of financial costs, it's much more than if you obtain primary closure. So going back to Dr. Beckett's, Jeep Willis, and Ogilvy's comment in 1940, I think it's about time that we prevent retraction of the fascial edges, that we are not working against ourselves by leaving the abdomen open without any mediation of the fascia or for days, and then we start to try to bring the fascial edges together. So Ogilvy in 1940 had already called the solution. And AbClo allows us to get an edge on the retraction of the fascial edge in patients with open abdomen. Thank you very much.